I'm curious. So for those of you that have just joined us, where did you hear about our roundtable from? Whether it was from social media, through email, from somebody else? Let's see.
My
Cameron,
name is Cameron. Yeah. Do you prefer us to use the chat or talk over Zoom?
Yeah, you can go talk, whatever. If you prefer to chat, that also works perfectly fine. It's just whatever you're comfortable with.
Yeah.
I also want to mention to you guys that we do plan on recording this. So if you aren't comfortable with your face, name, any of that being shown, we recommend that you change that as if in a couple minutes now before we get started. Yeah.
I was invited from the Spokane Homeless Coalition.
Perfect. That's great.
That's probably where I heard it too. I just discovered it on my calendar. I was like, oh, okay.
Yeah, great. I'm glad that that is where people are hearing it from. I love that group and it's a great way to share information.
Yeah, that's for sure. Well, my name's Emma. I work at Family Promise. So I'm excited to be here and learn about something that I've always been curious about, but I haven't much experience in. So I'm really excited about this as well. Hi, is it Louis or Louise?
Yeah.
Hi, Louise. We're just talking about how we heard about this opportunity.
I don't know because I don't remember exactly how I got it. I think it was through a WSU listserv or maybe the homeless coalition. Yeah, I can't remember.
Great. Well, we're glad to have you guys. I'm going to give it just one more minute and then we'll get started.
Louise, I'm glad I'm not the only one.
I just put things on my calendar and that's as far as it goes. I don't remember where it came from necessarily.
That's exactly what I did. I found it on the calendar. I'm like, oh.
Perfect time.
We live and die by our calendars. My boss called me the other day, Emma, where are we? What's this meeting we have in 10 minutes? And I was like, I have no idea. Let me search my email. Turns out he didn't even need to come. But it was a funny moment where I was like, wow, I rely on this way too much.
Yeah.
All right. Well, I think we should get started. Thank you guys for sharing that little information with us. It just helps us to know how we're reaching our audiences and how we can connect with you in the future too. But just for those of you who came in just a few minutes ago, we are recording. So if you have an issue, feel free to mute your screen, turn off your audio, any of that, and we'll get started. So my name's Emily. I'm an intern with Family Promise. And for those of you that don't know, Family Promise is an organization that works to end the cycle of family homelessness by equipping communities and families with the information and just kind of things that they need to get back on their feet, how communities can help and do all that fun stuff. So we define a family that is homeless as any adult who is caring for a child and that they are unable to live like in what we deem as housing. So it's not like in a car, you are not in doubling up at somebody's house, things like that. And primarily we focus on prevention, shelter, and then we also, like we said, prepare families to get into permanent housing. My job as a community engagement advocate is to work to prepare roundtables like these to inform the community on how we can do a better job for those who need help and how we can just become passionate and excited about helping our neighbors and our family members and just in any way that we can. So I would like to introduce our guest speaker, Marcia. She is a wonderful person. I am so glad I got the opportunity to talk with her and meet with her, and I'm so glad that she's going to get the opportunity to talk with you guys. She is an ER nurse here in Spokane, and I'll let her introduce herself the rest of the way and take it away.
Fantastic. Well, thank you very much for your time this evening. I do recognize time is valuable and appreciate everybody sort of taking a moment to focus on something that's near and dear to my heart, is how we care for patients in general, but certainly emergency services that are offered to the homeless environment here in Spokane. So Emily did ask me to speak about this. I am a Senior VP of Clinical Systems at a company called Engage. We used to be called INHS. We are about 25 years in the Spokane area, and we deal with healthcare IT, healthcare information technology systems. So that's my Monday through Friday job. And then, as Emily indicated, I've been a registered nurse for about 36 years and have been in various jobs as a nurse, but for the last, since I've been in Spokane, the last about 20 years, really in acute care environments, in the emergency departments in most specifically. So this evening, we're gonna kind of move on and talk about the way I look at the homeless environment, and certainly around healthcare. And I'm going to start from what drives services of care in our healthcare market, and then sort of how we look at this cohort of patients that we have identified in this population called homeless, and the impact on emergency services, and hope that all of you will gain really a perspective that is more than just sort of the patient as a human, but really what is driving our source of care in emergency services. We're going to talk a bit about some of the barriers that impact potential care quality and quality inequities, and then really talk about what we're seeing in terms of opportunities that all of you have to impact the care delivery system as it relates to this cohort of patients. So as Emily stated, I'm taking a kind of a broad look at defining sort of this homeless population. But really we look at the issue of the lack of a stable home environment, okay? And that can be, we call it a nighttime residence, that people do not have the stable place to sort of create a life infrastructure by which they can then do other things. So their energy may be focused on where am I going to spend the next night or series of nights. So it can be those that are staying in a public environment like a park, a car, those that are couch surfing or borrowing space through friends or relatives, but really are stressing and spending time and focus on their lives really about their next steps of basic human care, which is called a stable environment. So again, I'm going to take this from a healthcare perspective, and you may know this and you may not. So I'm going to kind of start us out on what is happening in the area of healthcare most recently. And so in the healthcare world, we are driven by and large by federal policy and laws and bills. We get our funding, primarily federal funding through CMS, which is the insurer of Medicare and Medicaid patients. And through those particular, they call it conditions of participation, through that funding of the healthcare environment, we are then driven to provide certain services. And by and large, healthcare policy and bills and laws really look at majority. How are you going to impact the greatest majority? Now, if you look at the healthcare spend in the United States in 2019, we have topped $3.8 billion, okay, of the healthcare spend. And that correlates to about $11,000 per person annually of healthcare services. And as you hopefully are kind of taking notes in your brain, you'll hear why that is so impacted in our healthcare homeless population and how they are impacting that dollar spend. But right now, as of April 1st, the healthcare IT services were provided a ruling from the federal government called the 21st Century Cures Act, which required us to begin to share information about healthcare with the patient and with other providers. On May 5th, that goes into effect by asking us as healthcare entities that provide services of care to automatically notify primary care providers that the patient has sought care. Now go back to our patient population. How many of those people have a primary care provider, right? So already we're losing an impact from a federal ruling, a federal law that all healthcare entities who are funded in part by Medicare and Medicaid that require us to do this, we're losing those people, right? Because they often don't have a primary care provider. In general, the assumptions by the federal government and what we believe to be true is that people who partake as an active participant in their healthcare decision-making and care practices are better healers, are better participants and healthy individuals. Again, this was the ARA initiative, American Recovery and Reinvestment Act of 2009, where the federal government began to incentivize hospitals and healthcare institutions to adopt electronic health records. And the reason that we adopt electronic health records is to collect data. It is not for me as a nurse to enter data, or in fact, it may not even be easy for me to provide care and to describe my care in an electronic format, although we really try. The idea of moving everyone, and we are at around 90+% of healthcare institutions today that have an electronic health record. The reason is to collect information, okay? And then once we collect information, we can then move it to the patient. We can move it onto your cell phone via the Apple Health app, and we can then move it to primary care providers so we can all of us provide the best care for you as an individual. There's another rule that came into effect in 1986 called the EMTALA ruling. And this is where the emergency department really sits in terms of the sole care provider for our homeless population. EMTALA ruling defines, it's the Emergency Medical Treatment and Active Labor Act, came in again in 1986 as a federal rule that requires emergency departments to not turn away anyone. Anyone that walks in emergency departments must be provided a medical screening exam. And most of us today equivalent that to treatment, regardless of financial citizenship, legal status, ethnicity, socioeconomic status, anything. That is the difference between any other setting of care and the care setting of an emergency department. That came into effect because in 1986, when people did not have insurance, ambulances were circling emergency departments for people in labor. We lost humans, we lost babies because all of us were diverting care because people could not pay for that service. Hence, the federal government stepped in and this ruling called EMTALA. Anyone can challenge that an emergency department would not provide them services of care. They can call the federal government and say we have an EMTALA violation. Every ER in the United States will know what that means. And we work very hard to make sure that people don't feel that way. The other thing that came into effect in the early 2000s was because now we have everyone adopting electronic health records. Now we have health data on individuals. We began to see that there are certain unique data points that we were not capturing that in fact impact your health as a human being. So health is not just defined as a physiological being, but what we found is where you live, your zip code, your access to health, your access to food, community gardens, the way people chose to live, whether you smoked or didn't smoke, those kinds of things. The social issues that impact your day-to-day life can actually impact your health as a human, okay? And we wanted to begin to collect that. Now, the reason that that is displayed in the COVID world is all of you have heard of the Johns Hopkins statements around the disparity of services and care of our ethnic populations in the COVID environment. The reason we know that is we have all this data. We have data because we have impacted healthcare institutions by the adoption of electronic health record. But what that does for us, and those of you who are going to impact the homeless population, is it gives you a database by which you can begin to say, I can change this. This is costing our GDP this much with this cohort, and this is what I'm going to impact. And you'll see some evidence of people using data in order to measure and demonstrate improvement of services. Now we're going to shift into a little bit more around the cost of care related to the homeless population. So again, I will say that emergency department becomes the source of service, care service, because we're required to. We are the only entity in the healthcare system in the US that is required to open our doors. So even though we have situations like Chad's clinic, the Denny Murphy clinic, other clinics that provide care to populations at large, in general, they are not open 24/7. They are not open, let's say, on the weekends. They don't have the access points that all emergency departments do for our population base called homeless. People with homelessness are, on average, when admitted, at least 3 nights in the hospital. That is significant because many years ago, the federal government began to require us as hospital and healthcare services to identify why you need to be in more than 24 hours. It's called the 24-hour rule. We have to double justify why you're in greater than 24 hours in an acute care setting. And God bless our homeless population. Sure enough, they're in longer. Why? Because we don't have a place to discharge them. Our homeless admission patients cost great more than our housed patient admissions. We can discharge patients to a stable discharge environment, home environment, where we can provide wraparound services like therapy services, home care visits, hospice nursing. We can't do that in the homeless populations. On average, our homeless population admissions cost $1,000 more than a housed patient admission, just by being admitted to the hospital. And when you start seeing the volume of these patients and the services that we're providing in this sort of care setting called emergency, that's really it's not appropriate services or care for that setting, you'll see why this $1,000 more really begins to add up. The other thing about the homeless population cohort is that their environmental factors that impact their human existence and their mental health and physical health and dental health really begins to add up in terms of their overall ability to heal. And so they have higher chronic disease problems that really impact our ability to well them, to get them better, to fix the problem. This is sort of an understanding. I wanted to make sure that we're aware, not only do we have a national influence in terms of the federal government and how we take care of people by bills, policies, and laws enacted at that level, but understand that homelessness is around the US everywhere. It should not surprise you that the West has a large population of homeless and homeless visits, because we are a warm, by lack of a better word, we're a warm climate. We have seasonal services. We really provide an environment that can service people that are in the homeless sector. In the Northeast and South, they have a less population of visits, but certainly if you look at those of you and I, who rarely go to the emergency department every year, the average visit by our homeless population, they visit 5 times. 5 times. And an average cost of emergency services care is $2,000. So we've got the policy that guides how we have to provide services and care in the emergency department. We kind of understand this cost of care in terms of the dollars. And by the way, alternative care, meaning care around an urgent care setting, if they would accept a homeless patient, which they do not have to, nor does a dentist office, nor does any other care service except emergency care. An urgent care visit, usually $100 to $200, as opposed to $2,000. A clinic average non-emergency visit, $100, and an e-visit, this new thing that's come out because of COVID, the video visits by our healthcare providers, around $50. $50 that you and I would pay for a visit with a healthcare provider. But how many of our homeless population has access to this lovely Mac device, right? Or a quiet environment by which they can have a conversation with a healthcare provider? It's non-existent, at least today, at least right now. So if we think about this, we have to see them in emergency services. That's the only source of healthcare. We look at then how we are being funded. Where is the funding coming from? Medicaid, right? The federal insurance by our government. For those that have insurance, they've got Medicaid, but more than likely, many are uninsured. We call it self-pay. You're not going to get money for self-pay. They don't have a source of income that we can tap into because we need an address. When you come into emergency department, if you're Medicaid, we want to see your card. We want to validate that we can bill that insurance, right? So if you don't have your card or the system where we double check Medicaid services to that individual are down, we will then convert them to self-pay. Now, here's the other real trickery with this patient population. So we admit them to the hospital. You know they're going to be in at least 3 nights. It's going to be more expensive than anybody else. Where do I discharge them to? Well, probably home. Where's their home? Well, it might be in the streets. And what happens within 30 days? They come right back and they're readmitted to the hospital. It's this cycle of health that we really need to make a cut in. We really need to make a separation in this readmission. In fact, readmissions to the hospital are followed by the federal government, and they will not pay. They will not pay if you're readmitted within 30 days for the same condition. For the same condition. So what am I going to do? I'm going to create another condition if I can, right? I need to get paid for the services that we offer. 70% come back to the ER. Yesterday, I worked for a few hours in the ER. We had a patient, broke his heel. We put a cast on it, got him a place to stay. 30 minutes later, he's back. We readmit them to the ER. That's a revisit, because once you discharge, we cannot then undo the discharge because something could have happened when they went out. So it's a readmission. Not only that, but 50 to 70% of the visits we see are inappropriate, meaning they're non-urgent, non-emergent. Dental care, scratches, I'm cold, alcohol, found sleeping, whatever, inappropriate for the $2,000 visit that they're going to incur, which cannot be funded, right? And we do have a write-off capacity in the emergency department and hospital sector in general. 77% of the homeless population is written off to charity care. Expensive services. And United Health's CEO said, look, our hospital beds and our hospital emergency services are very expensive. They're one of the most expensive ways to provide homes for our homeless population. Okay, so we got the law, we got the cost. Now we're going to talk about this human existence, this physiological being. Remember, we're from a healthcare sector, and if any of you have taken healthcare stuff, we learn about the body and how the body is supposed to act. Our care, Our treatment protocols are driven by research based on an average human body, most often males, but that's what we do. That's where the research is from, not on an unhealthy, unstable human physiological being. So their poor health not only contributes to homelessness because alcoholism leads to liver failure, leads to jaundice. They cannot continue to work in what we call the normal productive society. They get kicked out, they lose their jobs. Now they become homeless. So health can contribute to homeless, and homelessness can contribute to the overall health. Homelessness can contribute to overall health because of the lack of overall access. These are individuals who may not be able to get to a care setting that can provide services. And what I didn't show you or talk about on the last one, I think, was their transportation modality often becomes the ambulance, which is about $1,400 a trip versus a car, a taxi, an Uber, anything else. Folks have problems getting enough food. Malnutrition is a big problem for us. Staying safe, violence in the homeless population, a big problem, right? They're scared, they get hit, we have a lot of altercations. Lack of a stable residence. They go from place to place to place. Violence impacts our homeless population. Domestic violence, sex trafficking leads to situations where people find themselves out of a stable environment where they can have a nighttime of rest ongoing, where they can consistently say, I'm safe, I'm good. And what we know, particularly this year, has given us tremendous data on stress and anxiety. COVID in general, keeping people isolated, our need to be social beings and to interact has caused a great deal of increase in this situation called anxiety and what anxiety does to the physiological being. Stress responses, we get panic attacks, we get all kinds of behaviors because this world where we live in so much stress has led to this condition called anxiety. Living conditions without soap, running water, toileting, showers, a big problem, right? If I have a scratch and I cannot wash it for days on end and it becomes infected, now I have an infected scratch, and that requires medical treatment. And then of course, we know in Spokane, certainly any exposure to severe weather, whether it's overall heat and heat exhaustion, heat stroke, or whether it's cold, the cold environment where we open up the heating shelters, right? The warming shelters for our homeless population. We have had folks die under the freeway, right by that LC area, when we were unable to get those folks into a safe environment and they essentially froze to death. That's never good. In terms of common health problems, well, just for perspective, the most common health problem in the United States continues to be cardiovascular disease and the series of diseases around our heart. These folks in general, while they may have that, their diseases are generally compromised by community spread diseases like HIV and AIDS, where we share needles or share blood, whether it's deliberate or indeliberate. We have lung diseases, diseases that are shared by our respiratory system, certainly tuberculosis, pneumonia, and of course, we all know COVID. Up until this year, people did not wear masks normally, and so we are waiting to see. In fact, we had a much less significant flu situation this year. Again, people were wearing masks. We saw a drop in those particular cases. Malnutrition, as I said, again, remember our services in healthcare really are looking for, by and large, some level of a homeostatic physiological being so that we can treat them with medications or therapies that would be what we know to work. That's why COVID threw us off. Nothing worked. Mental health disorders, big problem. Schizophrenia being number one. Schizophrenia, by the way, tends to be diagnosed later in life, around 18, 19, early 20s, large group of male folks. It's a real problem for us. Substance abuse disorders in the Spokane area, certainly meth, heroin, and then alcohol. Alcohol, probably the number one disorder. It's very cheap for people to get. And they get it in a number of ways. Cough syrup. I had a patient drinking lemon extract the other day, I mean, and I'm not laughing. I'm just, our thing was, well, they probably smell well, you know what I mean? It's just so out of the norm of what you might think about experiencing. And then, as I said, this wound and skin infection, again, I had a patient the other day, an abscess, from shooting up inadvertently, got into the wrong area, didn't come in. The abscess then, grew bigger, whole body was infected, and now the patient has to be admitted. Very high cost of care for a condition called sepsis, which has to be treated very aggressively or people die. So now we're going to kind of talk about Spokane a bit. And I don't know, you guys probably all know these numbers better than me. And the point is not to debate about numbers. The point is to understand we have a group of persons that are in this homeless environment. They are a majority of them. Many of them are what we call unsheltered. And we do have a lot of shelters. I have this whole list that we use in the ER of shelters in Spokane that we help people get into, but they aren't long-term shelters. They're not the answer, right? They're transitional, they're emergency, that kind of thing. Large male population, less female. Now this is what was counted. I don't know what you guys, probably the coalition knows a lot more in terms of specificity of these numbers. But the point is that we have families, we have men, and many of you know much of the homeless shelters we service are divvied up like that. We have a large percent that take men only, and then women with children or families, and then our youngest population at Crosswalk, and then people with little tiny people. And Vanessa Behan, whether it's the crisis nursery or other places that folks can be cared for in those environments. Now, our particular problem with the shelters, it sounds well and good, but if you look back at what we talked about in terms of people who come in, okay, to see us, alcohol, drug, mental health, other contagious types of diseases. Well, there are rules when you go to the shelters, right? And they want certain behaviors, and they're broad. I mean, their guardrails are wide, but we have a group of people who are just unable to comply with those guardrails. So whether it's alcoholism or drug, and then they get kicked out, or they get into fights, and so they tell me, Mars, I can't go here, and here. Yeah, because they know they've already been banned. Well, when you get banned, what are you going to do? I mean, so we have to think about how we're going to deal with that group of people. There are groups of people who can comply, but when you're grouping homeless people in a area, again, we talk about contagious diseases. We talk about the ability to sort of do normal activities of life that you and I would do. Toileting can be a problem. Smelly clothes can be a problem. All those kinds of things that we are gifted to be able and blessed to be able to have showers and whatnot. In terms of Spokane, we do have Sacred Heart Medical Center. It has an emergency department and a children's emergency department. We have Deaconess Emergency Services up north. We have Deaconess Medical Center really close to Sacred Heart downtown. By the way, most of these shelters are downtown. If you've ever thought about that, our cohort of patients are nicely tucked in down there. Providence Holy Family up north has an ER. Valley Hospital has an ER. So all those services in the Spokane area are open. Our ERs are always open to anybody. Walk in and you're gonna be cared for to some degree. And then AMR is our ambulance service in town. And like I said, the gentleman with the broken heel not too long ago that we discharged out, we got a cab, we had a place. He went to the place, he got to the place. I don't know if he was there 10 minutes, someone called 911 and here he comes back via an ambulance. $1,400, right? I mean, it's just like, and we all knew it was him because his behaviors were such that he made lots of noises. And so we could hear him. It's like, I thought he left. He just came back. So it's just stuff we deal with. And then fire districts are transportation services as well. Okay, so our fire dispatchers all along the area, they will respond. Found down, nuisance, somebody's bothering somebody, those kinds of things. And even our police force, you know, they brought in someone not last week and said, I'm sorry, Marcia, but you know, he was, you know, it was the people around downtown that were, you know, just struggling with this person being there because the behaviors were odd. They weren't, you know, icky, and we see that too, but they were odd and made people uncomfortable. So we remember when I said the ER, well, you get a walk in the ER and then we're gonna see you, we're gonna treat you, and we're gonna do a medical screening exam. And then, you know, you're gonna be discharged back home. Well, discharge back home in their world, in our world, is the street. That's home. There's no other home. That's home. Now, again, we do our best to make arrangements for people to go to different places. But at Deaconess, they just lost their nighttime case manager. So then that role rolls to other people who are busy. So the amount of effort and time and energy we can extend, and plus the shelters aren't open. They don't accept people after hours, really. It's like you have to be there at 7 or some such thing. Certainly the alcohol-related disorders, substance abuse disorders, and other disorders are really, they're chronic conditions that we can't fix. You know, we can make sure they're not alcohol intoxicated to the point of dying, but that's more likely to happen with a college student. Alcohol intoxication to the point of than a chronic alcohol. Some of these folks walk around with 3 and 4 times what any of us, that's legal. I mean, that's just a day. That's normal day. And then, like I said, heroin and meth, real common to have behaviors that have allowed them to survive and that aren't really what we can treat and fix in the ER. The other issue that you'll find is the ERs really are not adept. We're not prepared for long-term homeless service resolution. You know, we can do an overnight bed. That's about as good as we can do. We can maybe, I'll talk about detainment related to the Ricky's Law, but really we're not prepared. And so what do? We discharge you to home. And remember I said they go around the corner and we're back, 74%. We're back. At least 5 visits a year, and often way more than that, depending on the frequency and the proximity to a healthcare environment. We do have case managers and social workers in most ERs today. They really do work very hard to provide resources to our homeless population. But again, an ER is much like a clinic. You're treated and then you're out. There's not time to sit and figure a lot of stuff out. We give bus passes. We pay for taxis. We do whatever we need to do to help ensure someone gets to the next point. But some people don't walk in the door when we drop them off. Some people say, hey, just drop me off at the plaza. I mean, we've had it all. So even though we work to do things that we would think would be great, helpful, super nice, it may or may not work. And then most recently, Ricky's Law was enacted by the Washington State, that allows us to detain those that either substance or alcohol harm to themselves. But we cannot detain you unless there's a spot for you, unless there's a bed. I can't detain you to stay in the ER. That's not the plan. The plan is if there's a bed we can get you to, then we can involuntarily detain you for grave disability or inability to care for self. So what do we have for training of the great folks in the ER? Well, we don't have a training around homeless because homeless is not an illness. Remember when we talk about education and we talk about medical and nursing, it's physiological. It may be some mental, not a lot. God, I look like I'm in the dark here. Sorry about that. I didn't turn on my light, but anyway, it's not an illness. It contributes, but we don't treat homelessness, right? So we really learn by street. We learn off the street. We learn by caring for patients who are off the street. That's how we learn. There's no curriculum. There's no plan. There's no even discharge instructions in our electronic health record that deal with homeless population. Nothing. I can put an address. I can send them, give them a map. I can give them a bus pass, but that's about it. The other thing about emergency services today is most ERs run a 12-hour shift. At the beginning of that 12-hour shift, you're pretty good. You can kind of stay strong, but over and over and over being hit by frustration that we can't make better, you get frustrated. And so there may be perceptions of prejudice or barriers to communication because we're frustrated with the problem that is presented to us that we can't impact in any way. So there's an opportunity, right? There's an opportunity for all of you to figure out what would work. Is there an app that you can give us that we can give to them and put it on the thing that would help? Is there an app that says, hey, when you're frustrated with the homeless, tap here and you do something great for me so that I can be, more pleasant? I don't know. But it's just us as humans in the emergency department, we're taught to fix and heal, right? Health care. And when we can't care and fix, it's really quite a toll on people. But look at the people that you have access to train. You've got providers, you've got mid-level or secondary providers, ARNRP, PAs, very prominent now in emergency department settings. Why? Because they're less cost of care. It should not be a surprise because we've already talked about funding. We've got social workers, case managers, we have psychiatric specialists, we have registered nurses, we have technicians, we have pharmacists, none of which are trained in the social ills of homelessness. Care opportunity for you. Man, I got to turn on a light. This is terrible. Hang on, sorry. This looks terrible. Little did I think, sorry about that. Now, here's what's exciting to me, and this is really where I challenge all of you brilliant young people. All right. When we grew up and we went to school and we were taught in the manner that I just said, which is no teaching. Now, I was raised, there were a lot of Vietnam vets. And so I had a lot of mental health teaching in my nursing. It was in the Bay Area of California. But today they have a section called psych nursing and that's it, 1 week, 6 weeks, I don't know what it is. But drugs and care services are coming out so fast that it's very difficult for us to maintain kind of up to speed on what's all available. So what we know today is that if we can get care to our homeless care service areas, if we can go to them or go to the places like, let's say, where the food is being offered. If I can provide a clinic there, I may be able to impact something. Okay. If I can partner with somebody to collect data on what would work, asking the individuals, if I did this, would you come? Yes or no? If I did this, would you? Can we learn about ways that better serve the population? Yes or no? They'll tell us. They're very honest. That, at least my experience. Wraparound services, domestic violence people, the YMCA does the YWCA, best services ever, man, for DV. They are so, oh, that's Frontier, but DV has wraparound services, right? They have counseling, they have legal, they have alternative housing, they have, I mean, they are all over it in terms of wraparound services to assist in working out of that social situation. The real thing we need to really focus on, which really, it has been identified, by the way, is identifying what the priority is. You know, I've given you a whole bunch of stuff about what we're trying to address in healthcare, but what can we prioritize? Can we prioritize alcoholism? Likely not. That is not where you're going to solve the problem. We can, however, prioritize housing perhaps. And I know that that is the service that Emily is working with in her area of internship. We can do things like provide prescription meds, right? We have the Suboxone clinics. We have the methadone clinics. People come. Listen, we don't mind you stop by and get your Suboxone on Saturday and Sunday if it'll keep you off meth. I'll do it. I mean, heroin and opiates, I do it all the time. And we provide that service. It's an in-out service. Can we look at different ways to address mental health? Again, big picture, are there other priorities you guys can identify? And again, substance abuse management. There is a lot today. We are learning a lot about opioids, how it got to the crises, what we're trying to do, but mental health, substance abuse, really addressing things like suicide prevention, those kinds of things right now for us, because those are really severe health issues for us today. But the good news is for this group of cohort is we have evidence to suggest that by providing housing, wraparound services in a stability housing environment, by the RID path, I don't care, help us discharge patients to a permanent, stable, longer term than one night housing situation. Is there something? Well, certainly the University of Illinois found that. The initial, but look at that, $250,000. But remember, $2,000 a visit, 5 visits on average of our homeless population. How many people are hitting our ERs every year? We can easily make up this money. Looking at grants, social service, research areas. And again, then providing identified wraparound services, identifying the cohort that you can impact. Now, what's interesting is I just sent Emily, and she can send it to all of you, $1 million grant by a program that National Geographic published it, by a housing program that's now going out to 65 cities in the US with $1 million grant. Again, this same pattern. They didn't identify that they matched with the healthcare organizations, but they did match with social service organizations in communities providing stable housing. So yes, we have malnutrition, we have chronic diseases, we have blah, blah, blah. But what we're finding is if we can provide stable long-term housing environment, that gives us a pause moment to say, what's next? What else? How can I help? What do we need? You know, then you can get computers. You can have clinics come to these housing areas. You can get ARNP servicing. You can get dental health. You can figure out ways to provide lower cost healthcare services just rather than the brick and mortar that we know today. And that's very exciting to me that we have identified housing to be a major issue. So it's been about 45 minutes. And are there any questions that you guys have?
Actually, there's a lot of questions that we
Oh.
got in the chat, so I can read them out to you if you want to address them.
Sure.
So let's see. First one, what's the difference between being able to walk in and not being turned away versus walking in and getting actual treatment? How do you determine who gets what?
Almost all ERs will provide actual treatment. And the reason is because community standard requires that type of care. When people, if we do not do service and someone can show harm, that's a litigation issue. So people that walk in, we will almost always draw blood, do an x-ray, those types of things to understand more than just what the verbal conversation is. So even if we treat it as a non-urgent or non-emergent, we will provide services that help us document and support our decision to not do further care.
Wow, very cool. That's just so cool to hear about. So if the high number of homeless treated or is high in the West climate, why is it milder in higher? Why is Midwest higher than South? Sorry, that was.
So let's think about that. That's a great question. So, you know, if you think about, the Midwest. So I was born in Nebraska, and it can get very cold. But the other issue about the Midwest is it has a lot of seasonal work. So we hire a lot of like people work on the farms, people that will do, let's say, pick strawberries or help us hay bale or those types of things that provide some level of income. And so they attract a certain group of people who can provide that kind of seasonal type work.
Great, yeah. Next question. I'm gonna try to get through these as we are running out of time. So let's see. Insurance rates in Spokane County are 95%. How many of the remaining 5% is homeless? If you know, if you don't know, that's okay. We can always try to get information back.
They believe that 95% of the people in Spokane are insured. Is that what that means?
I am not sure. Who person who asked if would you like to explain or elaborate? If not, that is totally
Well,
fine.
even if so, if you have 1 million people, 95% have insurance. We'd have to look at what percent is Medicaid and then what percent is self-pay. And then in terms of the ER, again, you have to sort of prove, like show us your insurance card when we ask for it, or prove that you're you anyway, which is a risk.
Well, and what that comment came up, I think, when you were talking about, you know, is somebody considered self-pay or insurance covered or whatever? And I think that idea of having to prove that you have the insurance coverage that you claim you do is going to be the larger issue. So even if Spokane is covered by is 95% insured, I bet that it is a lower number that can prove that they are insured.
Yeah, I mean, we have to have a billing address. We have to have a billing that, situation. And, oftentimes people don't even have an address, or they'll make up a phone number of 509-123-4567. I mean, it's like, what? Come on.
Yeah, the lack of a permanent address we see that all the time, but yeah, interesting how it shows up here.
Yeah.
Great. So I know some said if when you talked about people coming in drunk or asleep, who brings them in is the question we got.
Yeah, most people that bring in are going to be a fire department or an ambulance. So somebody sees someone laying on the road, they'll call 911. Fire is typically first to respond, and they'll bring them in. And in general, we call it let us sleep. We let them sleep it off. Like we won't discharge somebody who's sleeping. We'll let them sleep it off, and they'll leave in the morning, oftentimes.
Yes. Speaking of that, when you talked about readmission, somebody asked, do you think the readmission policies are good or bad? Do you think there needs to be changes that are made to them?
Well, I think we have to do a better job of looking at why are you coming back? What is it that I haven't done that has made you come back? Is it getting worse? Which typically we say if it's not better in 2 or 3 days, come back or go to your doctor. Well, if they don't have a doctor, we're their doctor. There's a lot of social ills, right? There's loneliness, there's cold, there's hunger, and we'll feed people. I'll give them a lunch every time. So I think there's a lot of reasons to come back. Maybe it's not safe. Maybe they were in a violent, there's someone harassing them, we see all kinds of stuff. And I wouldn't say not coming to, I wouldn't say closing the ER door is the answer. That would not be what I would suggest ever.
Yeah. I got 2 more questions here in the chat. Spokane Street Medicine I think this is just a comment. Spokane Street Medicine is seeing patients on the street in shelters, and they said they would love to connect better with emergency departments.
Yeah, you're not on my list. There's no list that says you, none. And this is the list I got from the case managers. I'm just telling you. There is something called Recovery Cafe, but
Well, I'm here connecting with you right now.
great.
Yeah, that's why this is like a great opportunity, these roundtables, just to like connect different people, learn about different opportunities, make people passionate. This is like just great conversation.
I actually have my friend is the chair of the Washington State Pharmacy Association, Chris Greer out of St. Luke's. He was a pharmacist there. So that would be the team that would love to connect to figure out how we can do better.
Yeah. So do you know of any current cities that incorporate stable housing for the homeless population that has been modeled well, that you see going in a good direction?
Yeah, I think you need to share that article, Emily, that group, I can't remember their name, that National Geographic that just won that $1 million grant. They've proved, they were able to measure it and prove it in, what did it say, Emily, 5 or 6 cities?
Yeah, it was close to that.
Yeah, so she can send that, or I'm happy to, I don't think I put the link in here, but once you start studying something, then everything that pops up in the news has that name in it. So I was sending Emily little articles all week.
It's been great. I love learning it.
Yeah. And then of course, University of Illinois, talking to them, certainly partnering with insurance companies. They are very interested in lowering the cost. So, Kaiser, others that have influence in Spokane, United Health, Kaiser, those kinds of things would be great partners.
All right, I have another question here that just came in. Although homelessness is a complicated topic and there are many factors that contribute to it, in what ways could healthcare community be working towards alleviating some of the causes of homelessness? And what ways can we advocate for easier access to healthcare and dental care?
Yeah, I think that's the biggest thing we could do. And I do think that, maybe a partnership with one of the organizations and somebody like Multicare or Providence to stand up, a visit like that would be terrific. I know that we did have, for a while, we were shipping people to one of the hotels to provide like home care services. Because it was cheaper than putting them in a hospital. Providence was doing that. But the part of the barriers in healthcare, we're a little bit egotistic, particularly in this city, very competitive. So I think we want to try to, say this is global for the good of Spokane, good of humanity, who will partner with us. But most healthcare organizations and insurance is very, very willing to look at measurable solutions based on data.
Well, thank you. I now want to hand it off to Emma just to talk a little bit more about Family Promise and how this all connects.
Great question. First, though, I have a notification that Becky raised her hand.
Oh, sorry.
Did you mean to raise your hand, Becky? Do you have
Yeah,
a question?
no, I did. And I'm pretty sure Sherry's part of the Homeless Coalition here in Spokane has a new subcommittee that is working hard to come up with a statement that talks about providing the homelessness with a stable environment. There are a lot of parts to that statement that they're preparing. And I was just wondering, because Marcia says so many of the same things the committee has been saying, if she would be willing to add her name to it. Eventually, we want to send this out and get as many, or they want to send it out and get as many people to promote it as they can. And I was just thinking, with all the things she's saying, which is what the Homelessness Coalition is trying to also say, if she'd be willing to participate. And if so, could she put her contact information in the chat?
I think I put it, yeah, happy to. And I have it on the, are you going to send out the slide deck, Emily?
Yeah, I can definitely send that to the Spokane Coalition.
Didn't I put my name and phone number on it at the last?
Yes.
And you guys can call me, or my cat brought in a mouse and my daughter's freaking out. Oh, sorry, my distraction. But yeah, no, and you know what happens in in my world is I do have a lot of network connections, right? I've been in the business a long time, and certainly in Spokane at least 20 years. So we would love to connect and do what we can to help.
Emily, are you familiar with Joan and Ken's committee? Do you know which committee I'm talking
but
about?
I'd love to learn more about it.
Okay, well, Sherry is listening. I don't know if she has more contact information than I do, because I think she's involved in committee. I'm just on the sidelines.
Yeah, maybe we can put, I love the networking. And then Luis also maybe wanted to connect with somebody over in the emergency departments. So if anybody would like to share their contact information, now would be the time to put that in the chat, so that whoever else needs that information can just snag it and make a note to call or email later. Perfect. Thank you, Marcia. I do want to say a quick thing about Family Promise. Obviously, Family Promise is the host for this event. And the reason for that is because we, as an organization, very much believe that homelessness is a symptom of a greater issue, of greater problems that are going on. And so Marcia was able to kind of shine that light on some of the health concerns, and how, you know, it's the chicken or the egg, right? And they go kind of hand in hand in hand. And Family Promise is committed to serving the entire family unit. So when we said earlier that we define a family as any adult caring for a child or who's pregnant, that's like exactly what we meant. We are as low barrier as we possibly can be. So if you know somebody, or as you're thinking about this issue moving forward, to be low barrier to us simply means the only things that we require for somebody to access care through Family Promise is that they have a child in their care or they're pregnant. It does not, okay, you can't steal a child, but it does not have to be your child. It could be, you know, a younger brother or sister. It could be a grandkid. It could be your adopted goddaughter. You know, like there could be a lot of different connections, because community and family looks very different. So we don't, you know, we don't discriminate on types of family, but you do have to have a kid. You need to be able to pass a national sex offender check. That is our only barrier. We do not require sobriety of any kind right off the bat. We, you know, come on it. And then the third is obviously if we have room, which, like Marcia was saying, is a problem throughout the system. One of the commitments of Family Promise in the months to come, and I'm actually really excited about this, is Family Promise is opening a respite center. The Family Promise Respite Center will serve families that are being discharged from the hospital and will provide that stable place for their recovery. And we're really excited about it. We're going to equip it with specifically talented and trained medical professionals who have a heart for the homeless, as well as ensure that the facilities themselves are good. So that's down the Family Promise dream pipeline. Hopefully here in 2021, it's obviously a priority, as well as an infant shelter. So obviously you can only walk into an emergency room if you can walk. And so Family Promise is committed to being there for families that have infants. For the last, something like 2.5 years, we have had a newborn in our shelter every week. So we've had something like 200 babies born into homelessness that we have served at Family Promise. And so what we are doing and what we're committed to doing is building out our care for families that have infants, because not only are you then dealing with homelessness, which came with all those issues that Marcia was talking about, you have no real immune system, and you're not vaccinated of any kind of illness, and you're in all of these environments. And if you're a preemie, you have other health things. There's just like lots of stuff that piles on. And so Family Promise is here in the community, and we're committed to doing our part. If you want to learn more about specifically what Family Promise does and what we're all about, we do have a really neat info night coming up. That's going to be next week. Emily?
Wednesday at 6 p.m.
Perfect. Next Wednesday at 6 p.m. We'll be sending out an email to all of you to be able to register for that as well if you're interested in jumping in to learn more. But yeah, we are committed to be part of a community that cares for everyone, just like the emergency department is committed to caring for everybody that walks through their doors.
Well, thank you guys so much for choosing to attend this event. We really appreciate that you want to put in the time to learn more and just be here to support our community members that cannot support themselves at the moment. If you ever have any questions, feel free to get in contact with any of us at Family Promise. And I'm sure Marcia would love for you to reach out to her too. And I really appreciate you guys attending. Thank you.
Have a good night. Thanks, everyone.
Thank you, Marcia.
Becky remembered. I love that.
When you said roundtable, that reminded me, I was in a meeting last week with Craig and he mentioned it, and that's how I knew about it.
There we go. Nice
Great.
job, Craig.
Yeah, I was to say, I wanted you to be able to tell Craig that.
Oh, bye. Sherry, you're still with us. Are you here?
I'm just leaving.
Oh, no worries. Thank you so much for tuning in.
Yes, it was very good.
Good.
Thank you.
You're so welcome. Bye. Okay, bye.
That went really well. Yay.
Nailed it.